Welcome to the North Carolina College of Resuscitation. I'm Jamie Jollis. I'm a cardiologist at Duke University. Along with thousands of colleagues in North Carolina, we're all working to improve emergency cardiac care.
I'm Granger. I'm a cardiologist at Duke University, and I'd like to welcome you to this series of presentations on a very important project for the state of North Carolina. That is the Heart Rescue Project, or RACE CARS. And this is the project to improve survival for patients with cardiac arrest by 50% over 5 years in the state of North Carolina. And it has a series of proven interventions that we need your help with, that include interventions in the community to increase rates of bystander CPR and to educate the public to activate the EMS system when a cardiac arrest is identified. It involves the best practices by emergency medical services, including rapid application of defibrillation and best care in transportation and destination to the best centers able to care for patients with cardiac arrest, and then hospital measures that include primary PCI when that's indicated, therapeutic hypothermia, and best care for patients with cardiac arrest during their hospital phase, including consideration for implantable defibrillators. And by doing all of these things, we believe that we can be very successful in improving survival for patients with cardiac arrest.
Today we're going to talk about one of the leading killers, cardiac arrest, and I'm going to review the epidemiology, or who are these patients, where do they live, how do they present, and what can we do. So we estimate that somewhere between 230 and 325,000 Americans have a cardiac arrest each year out of the hospital. And while I'm talking to you today, there'll be 20 more cardiac arrests. Most of those patients won't even make it to the hospital, and maybe one or two will survive. It's the third leading cause of death, and has a very high morbidity and mortality. So 80% of patients who arrest don't make it to the hospital. Now, if you look at patients who are treated by EMS, the average age is 67, so it's a bit older population. What's called the interquartile range, or from the bottom 25% to the top 75%, is between ages 53 and 79. About a third of the patients are women, and this is going up as women and men live longer and are more likely to suffer heart disease. Where these arrests occur is very important. Most of them occur at home, 82%. Public places, 16%, and other places like healthcare facilities, 2%. And as we think about cardiac arrest, we really want to think about what type of arrest, because that really tells us clues about first etiology as well as about the treatment. So asystole is the most common presentation, or just no rhythm whatsoever, at 40%. VT-VF is next at 23%. So these are shockable rhythms, ventricular tachycardia and ventricular fibrillation. PEA, or pulseless electrical activity, is 20%. These are patients who are more likely to have things like respiratory arrests, which the treatment may be somewhat different. And finally, other or unknown rhythm, 17%. Cardiac arrests are very confusing situations sometimes, and the rhythm's not always clear. So looking at the causes of out-of-hospital cardiac arrest, about 60% what we consider cardiac, and 40% we consider non-cardiac. So going through the cardiac causes, ischemic heart disease is probably the most common, and then other non-atherosclerotic coronary artery abnormalities, next cause. Cardiomyopathies, or an inflamed heart. Valvular heart disease, or leaking valves between chambers. Infiltrative and inflammatory myocardial disease, for instance, a swollen heart. Congenital heart disease, you're born with something that doesn't work quite properly and it finally presents as a cardiac arrest. And finally, some kind of electrical abnormality. Your heart has a tendency to go into VTAC or VFib. This can happen just out of the blue. If we look at the non-cardiac causes of cardiac arrest, these would include trauma, bleeding, for instance, bleeding out of an ulcer, pulmonary embolism, a very common cause in someone who's been bedbound or traveling on a long trip, suicide or drug overdose, lung disease, suffocation, drowning, cancer, and then SIDS, or sudden infant death syndrome. Now, from another perspective, not the EMS, but rather autopsies, if we take patients who had cardiac arrest, this was out of a series of patients from Nottingham in the United Kingdom, what was found in autopsy. And they divided patients into two groups: those who had a VF arrest, or the typical shockable kind of rhythm we think we have with cardiac disease, and those who had other rhythms, including asystole and PEA. And so for these patients, it's amazing actually how similar they were in terms of autopsy findings. About half had previous MI evidence, including scar tissue. Looking at coronary artery disease distribution, about a third, or maybe almost 40%, had three-vessel coronary disease, or most of the blood vessels blocked to their heart. Another 15 to 20% had two-vessel coronary disease. So coronary artery disease is very common in these populations. Not surprising because their average age in their 60s, but also coronary disease and cardiac arrest go together. Thrombosis, this is a medical term for a clot in an artery, and it implies there's been an acute myocardial infarction, is also present in about 30% of patients, either VF arrest or other arrests. And finally, left ventricular hypertrophy, or a very thick heart, is present about half the time in both patients who have VF arrest or other types of arrests. So basically, we're talking about patients who've got a lot of coronary disease, some scar, thick hearts, and regardless of their presenting rhythm, they tend to have the same findings on autopsy. And now thinking over time, have things improved? When I first started, we didn't have such AEDs available. Our CPR wasn't quite as good. We didn't have protocols. The emergency medical services didn't start to respond with defibrillators till, let's say, the early 70s, late 70s. Have things improved? As far as we can tell, absolutely not. Looking at out-of-hospital cardiac arrest survivors in 5-year time periods, it appears the overall survival rate is 7.6%, and going back to 1980 all the way to 2008, this rate is fairly stable. So despite all of our efforts, it seems this rate is pretty much standing still. And that's the reason we're all here today with this training program, is to change this number, at least in North Carolina, to improve survivors. So how about North Carolina? What goes on in our state? Well, it turns out that cardiac arrest is about as common as acute myocardial infarction and about 3 times as common as, let's say, deaths from motor vehicle accidents. So it's a major public health problem in North Carolina. We estimate that somewhere between 5,000 and 8,000 North Carolinians have a cardiac arrest out of hospital each year. And speaking with the North Carolina Office of EMS, the data show of 5,000 records they looked at, about 35% EMS was able to get return of spontaneous circulation or get a pulse back. And then another 1,000 of those patients, or 20%, got to the emergency department alive. Of those who reached the emergency department, 589 were admitted to the hospital alive. So 11% of the original cardiac arrest get admitted to the hospital. And while the numbers are not quite available, we estimate that maybe half these patients are discharged alive. So really, just like the national averages, maybe 5-7% of patients who have cardiac arrest in North Carolina actually make it out of the hospital. Really a very low number and a very concerning situation. Now, when you talk about who survives cardiac arrest, it's very important we use the same terminology. So if one city is saying our patients survive because we're looking at all cardiac arrests, another city only looks at shockable witness arrest, they'll have very different outcomes. So because of this variation in reporting, the experts in the world got together in Norway, in an island near Stavanger called Utstein, and they came up with this classification of cardiac arrest death. And so first of all, they said, is out of hospital or not? Then was resuscitation attempted? Then is it cardiac etiology? Then is it witnessed by a bystander? And then is the initial rhythm VTVF? And those patients who are out of hospital, cardiac etiology, witnessed and VTVF arrest, this is called an Utstein type cardiac arrest. And this is the ones we really aim at we think we can make things better. So once again, going back to North Carolina data. Now, these data are compiled from 3 major cities in North Carolina, Charlotte, Raleigh, and Durham, are actually the counties involved in those cities as well. They all work with the CARES registry we'll talk about later on, and really an excellent source for looking at public treatment of cardiac arrest. So looking at the CARES registry for these 3 North Carolina regions combined in 2010, there were 1,096 resuscitations attempted for a cardiac etiology, cardiac arrest. Of those, 396, or about 40%, were witnessed by a bystander. Looking at those witnessed arrests, 107 were asystole, 164 were VTVF, and 125 were other rhythms, including PEA. So this witness arrest, the VTVF, is actually fairly common among this group. So of those people who were resuscitated, the VTVF, 104 had return of spontaneous circulation. Of asystole, only 39 had return of spontaneous circulation. And of other rhythms, 63% or 63 had return of spontaneous circulation. So somewhere between a little over half to less than half of patients, they can get a pulse back. Admitted to the hospital, looking at VTVF or the Utstein group, 82 of these patients were admitted to the hospital, and 48 were discharged live with what's called a cerebral performance category of 1 or 2. These are people who can return to functional lives and take care of themselves. For asystole, of 22 admitted to the hospital, only 3 were discharged with a CPC of 1 or 2 with good function. And finally, of the other rhythms, 15 admitted to the hospital, only 14 were discharged with good function. So it appears that for the most part in North Carolina, at least in 2010 in these 3 metropolitan areas, the VTVF arrested patients who can be resuscitated have the best chance of making it out of the hospital. So this slide summarizes the findings of this data from the 3 counties in North Carolina for 2010, and we hope to have more data soon. I was pretty surprised by these actually. Of 924 arrests witnessed by bystanders, only 12, or 1.3%, had an AD applied. We think this number can be much higher with just a bit more work in public training. For CPR in these metropolitan areas with great systems in place, 217 patients, or 23%, had bystander CPR. Our guess is statewide this rate would be much lower. And here's another place where we can make a big difference, I think. And then looking at these different survival rates according to the type of arrest, it ranges from the 4% survival for patients that are unwitnessed arrest, and those are the ones, for the most part, by the time we get there, it's just too late, up to 40% for the shockable bystander arrest, which is really the ones we think we can save. And these 3 areas in Charlotte, Wake County, and in Durham, I think really do an outstanding job, and other places across the state. And this variation is very important. There's a group called the Resuscitation Outcomes Consortium, and they looked at this group of VF witnessed arrest to see what survival was like in different cities. What you see here is survival rates ranging from about 40% for Seattle down to 7.7% for Alabama and 9.5% for Dallas. Now, why are these places different? There's 2 possibilities. One of them is, despite this Utstein reporting, we're still counting deaths differently. So maybe Seattle just has better survival because they're counting fewer patients that die, and Alabama and Dallas look worse because they're counting more patients that die. But another possibility is there's just differences in the way that these cities are organized, and we believe that's the case. For instance, Seattle is home of Seattle Medic 1, which 2 years after North Carolina put into place our paramedic program, they followed us and have an excellent program for cardiac arrest. Seattle is where the Physio 33 came from, the first portable defibrillator. And Seattle has great public training, maybe 40% bystander CPR rate, double that of North Carolina. So in Seattle, they have a different approach to cardiac arrest, very well organized, and we believe that's probably why people do so well in Seattle. We have regions in North Carolina, as I showed you, like Charlotte, Raleigh, and Durham, that can do this, as well as other cities across the state. I mentioned a couple, Asheville, Winston-Salem, that can do this as well. And we believe that we can get everyone up to this 40% survival rate. This is our goal. So now I'm going to talk about who survives, because this is really important in understanding what we can do to change these rates. And I'm going to use an actual case. This is Amy Jones. Amy lives north of Charlotte. She is 37 years old when this happened. She was 9 months pregnant. She had 2 days to go until she was having her baby. And it's about 11:30 at night. She feels terrible. She's downstairs on the couch, and she just feels awful. And she just wants to have this baby. And she tells her husband, it's late. Why don't you go up to bed, and I'll just be down here on the couch. I just don't feel like walking upstairs. But he decides to stay downstairs with her. And he notices a bit later that she's breathing funny. She's doing what's called agonal breathing, which we'll have some examples of later on. And she's turning blue. And he's not trained in CPR, but he knows something's wrong. And he calls dispatch 911. And on the phone, they talked to him about his wife, and they recognized she's having a cardiac arrest, and they actually explained to him how to do CPR and follow him while he's doing it. At the same time, they dispatched the local fire station to go there. We'll get there 7 minutes later, and they apply an AED. The AED gets 3 shocks, and she gets a weak pulse back. And then she gets 2 more shocks while she's being transported to the hospital. When she gets to the major medical center in Charlotte, they actually deliver her baby by C-section. And then they treat her with hypothermia. They cool her for 24 hours according to their cardiac arrest post-resuscitation protocol. She wakes up, she goes home day 10, and now she's totally functional. Had a little delay in her memory coming back, but now she's completely with it. It's an amazing save. And this kind of thing happens all over North Carolina in places like the Charlotte region and others. So why did Amy Jones survive? Well, first of all, she was lucky her husband didn't go upstairs. This was witnessed, and that's important. People we don't witness, we're going to have a much harder time of bringing back because her response is just too slow. Secondly, her husband recognized this and called 911. And even more importantly, on that call, the medical dispatch recognized the cardiac arrest as well and gave that instruction on CPR. And then really that's the big difference, that by-center CPR doubles the rate of survival. Without that, she probably wouldn't have been able to wait the 7 minutes for the fire truck to get there. And then there was this rapid dispatch. So right down the street, the fire station gets there, they apply the AED, she gets shocked, she gets a pulse back. And then lastly, with all these pieces in place, she gets excellent post-cardiac arrest care, she gets cooled, and we believe this saves her brain, and she does well. This slide shows actually is Amy Jones, she's in the middle, and she's holding baby Elizabeth in her arms, she was totally fine. And there's the fire crew that responded really quickly and saved her life. This is a great story. We want this story to be repeated every place across North Carolina for all the baby Elizabeths to save their moms and dads. So as we look at studies of who survives, more likely to be hospitalized, that surviving hospitalization, as I said before, only 2 out of 8 patients make it to the hospital. Women are more likely to survive. And also, if they're by-center witnessed or they get CPR, twice as likely to make it to the hospital. Who's less likely to survive? The elderly, over age 75, and then arrests at home, which is really related to not being witnessed and not having somebody nearby to respond. Looking at patients who survived to 1 year among 830 cardiac arrests, in this study, if they were witnessed by the firefighter, so they've called, they're sick, firefighter gets there, and then they have their arrest, more likely to respond. And again, less likely to live to 1 year, over age 75, arrested at home, a long response time, so greater than 12 minutes in the study, people didn't make it as much. And lastly, getting 4 or more shocks, which I believe is just a demonstration of just the worst cardiac arrest, being down longer, being sicker. So, things we can't change. We can't change witnessed, and we can't make people younger just yet. Things we can change, by-center CPR, a no-brainer. And this response time of less than 9 minutes is something we need to aim for. And there's many challenges here, but we got to get there quickly. So now I'm going to talk about some research and some strategies that have been published for improving survival. How can we move above the 7.6% survival rate for cardiac arrest? How are we going to move things in North Carolina? This is something you all recognize. This is from the most recent American Heart Association emergency cardiac care guidelines for surviving cardiac arrest. This is the chain of survival for adult out-of-hospital cardiac arrest. So first of all, you need to immediately recognize this and activate the emergency response system, which in this country would be 911. Next, you need early CPR with an emphasis on chest compressions. We'll talk about this more, but really just get on the chest and keep pressing until they wake up or they say stop. Rapid defibrillation, getting the defibrillator deployed, getting a shock in. VTVF can be turned around very quickly with a well-applied shock or two. Effective advanced life support. All of us healthcare professionals respond to codes to cardiac arrest, and sometimes it can be fairly panicking, especially if we don't see them very often. What we need are people experienced and calm and organized in responding to cardiac arrest. We have many examples across the state, both in hospitals and out of hospital. We need to keep raising the bar on advanced cardiac life support. And finally, the last piece is this integrated post-cardiac arrest care. We have many hospitals in the state that are really organized around post-cardiac arrest care, and this includes plans on who goes to the cath lab or who gets hypothermia, and even things like neuro rehab and how to take care of the family. It's really organized around this post-cardiac arrest care. But unless we get them to the hospital alive, it doesn't matter what we do with the major medical centers afterwards. So as part of this chain of survival, the American Heart Association came up with a consensus statement for improving survival, and I'll review some of these. And these are things we're targeting in North Carolina and nationally as part of the Heart Rescue Project. So first of all is medical leadership. So everyone on this video and everyone watching it, you are all part of this leadership, which is so crucial to taking care of these patients and making things get better. The next big piece is the community. We need more bystander CPR. We need to double our rate from 20 to 40%. And then public access defibrillation. Where are these defibrillators? How do we find them? How do we use them? Can we get more of them? Next is dispatch. We want a rapid response, and when someone calls with cardiac arrest and it's recognized, we want, if they can't do CPR, we want the instruction to work, and I'll show you some data for that. For EMS, we have excellent EMS in North Carolina with great leadership and great resources, and we just want to continue to work to have high-quality CPR and early defibrillation. And finally, for hospitals, all hospitals should be able to take care of cardiac arrest, and there will be some that choose to have specialized facilities, such as hypothermia and neuro rehab. You need a multidisciplinary team. I'm a cardiologist, which I joke I'm a plumber. And with these patients, I need emergency medicine, I need nursing, I need administration, I need pharmacists, I need neurointensivists. It's a huge team, social workers, obviously emergency medicine is a huge team of people working together. And it's quite different than being in my little cardiology silo. Early PCI is percutaneous coronary intervention or early angioplasty. So if the arrest was due to that thrombosed artery that we see in 30% of patients, opening it quickly because that saves lives. Therapeutic hypothermia, so cooling somebody to prevent brain injury. And who do we cool? Somebody who's not following commands after they're resuscitated. And then early hemodynamic optimization. When you first cool these patients, their blood pressures drop. When someone has a cardiac arrest, all kinds of things go poorly in terms of vital signs, electrolytes, and organ function. You need to stabilize them in intensive care units. And finally, if they survive and they're mentally intact and they had out-of-hospital cardiac arrest, I believe most patients should get an ICD placed because really this is a disease we can prevent in the future with an ICD. An example of this broad application actually comes right from North Carolina, from Wake County, from Brent Myers and his colleagues with the Wake County EMS. They took the 2005 guidelines, the previous iteration, and they applied them throughout Wake County, everything recommended. And looking at their baseline survival of cardiac arrest to their subsequent survival after 5 years implementation, they increased from 4% to 11.5%. So huge changes in survivors of cardiac arrest. And more importantly, the CPC 1 or 2s, neurologically intact survivor, they tripled this in Wake County. So if Wake County can do this, implementing things, we believe with their leadership, we can all do this. So I showed you rates that we're having 1.3% of cardiac arrest victims who have bystanders have an AED placed. And why is that? Are AEDs worthwhile? Is there any data out there to suggest that AEDs can make a difference? Well, my first statement would be, whenever I see an AED, if I see a sticker on there that says only to be used by trained personnel, my tendency would be to take that sticker and scrape it off there. AEDs are designed for anyone to use. They've done studies where they had 6th graders versus paramedics use an AED, and the paramedics were about 60 seconds faster at getting it to fire than the 6th grader. So anyone can use an AED who can open a box and read, and really get it to the patient, open it up, follow directions is my big message here. What about data? There's a randomized trial published in the New England Journal, looked at public access defibrillation and then training how to use AEDs. And they picked 993, they call community units, in 24 North American regions, including the United States and Canada. And these units were defined as having 250 adults over age 50 in that area for 16 hours a day. So they're targeting that older age group that we see who has cardiac arrest. These units also had to have an AED available within 3 minutes. And then they randomly assigned the shopping malls and apartment complexes mainly to either usual care, which would be having the AED there, versus training on how to use the AED and to have a community response to that. What they found is this training made a difference. If you look at the data, particularly looking for survivors of a definite arrest among public units, they doubled it. They had 14 survivors in places without the training versus 29 survivors in places with the AED training. So they doubled the rate of survival in these public places. Residential units were less in these data, optimistic. Really no difference in the outcome. And that's probably because a lot of the residential arrests were unwitnessed. An apartment complex at night, no one's around. So I think these data clearly show if we put AEDs into public places with lots of adults most of the day, particularly things like shopping malls and airports, and we train people how to use these AEDs, we can really make a difference and save lives. So it's not just having them in place, it's putting them in the right places, it's knowing where they are, and it's training the public on how to use them. One of the most exciting things in cardiac arrest, at least for me as a healthcare professional, is what's called high-performance CPR. So as a cardiologist for years, we often have people who have VT or VF in the cath lab. It's just part of the nature of taking care of heart patients. And we're actually really good at getting someone back very quickly. And so we don't even panic, we just move quickly. But something I've noted over the years is what makes a big difference is who's doing the CPR. We actually have a catheter in place. We can watch the pulse pressures. And my favorite cath lab tech, his name is Jollis. He weighs about 250 pounds. He's solid muscle. And when he's on the chest, he does his chest compressions, and that pressure waveform is going way up. He wasn't measuring. Is he doing inch, 2 inch, 3 inch? He wasn't counting slowly. He was doing it quickly. And when Julius is on the chest, that patient's going to make it. No problem, no injury. And this was my observations over the past 20 years. Well, now that's become codified based on research and recommendations. This high-performance CPR with rapid, effective chest compressions and a concentration chest compressions does save more lives. And I'll show you the data for this approach and Julia's. So why do we like this? First of all, I think bystanders as well as healthcare professionals are more willing to initiate. For those of us in healthcare professions, we're always going for the chest, and you don't want to do the mouth-to-mouth part. Secondly, when someone has a cardiac arrest, they have plenty of oxygen in their blood when they first go down, so there's no need to do the respiration part. Thirdly, if you're not blowing air into the stomach, you're less likely to have regurgitation of stomach contents. And probably most importantly, when you stop to do rescue breathing, you interrupt these critical chest compressions, and I'll show you the data on this shortly. It's much easier to teach. We only have a 20% bystander CPR right now. We believe with mass training, with chest compression only, we can really make a difference. And finally, there's evidence, and I will show you that this actually leads to improved survival. So this graph right here is a bit confusing unless you happen to be a hemodynamic researcher or a cardiologist, but I'll just go through it really quickly. This is an example of pressure tracings for CPR with 15 chest compressions followed by 2 breaths, or one of the standard recommended regimens from the past. What you see here are some colored lines. Most importantly is the yellow lines. This is blood pressure in the right atrium. And the pink lines, this is blood pressure in the aorta. So coronary blood flow goes from the aorta to the right atrium. So this pressure gradient is needed to drive blood across the heart muscle. So what you want is a high pressure in the aorta, a low pressure in the right atrium, and with that gradient you get coronary blood flow, which is the point of doing CPR. The green spikes, that's just noise from the compressions themselves. So what you see here is a lot of green spikes followed by a pause, and then more green spikes followed by a pause. And that pause is for this, the 2 breaths. But more concerning, what you see here is these pink and yellow lines. You really don't get a good gradient till the end of these 15 chest compressions. Now you've got a good gradient between the right atrium and the coronaries, and just when things are going well, you stop, and that coronary pressure drops back off. And you start back up 2 breaths later, and it takes 15 more compressions. You're finally getting to where you need to be, and you stop again. So literally, it's ineffective because you're stopping just when things get going well. And what these data suggest to researchers and also from evidence is that keeping that gradient all the time, it makes people more likely to survive cardiac arrest. Do not interrupt chest compressions. I think it holds both for bystander chest compression only CPR, but also for healthcare professionals. That if this is a cardiac arrest, keep the chest compressions going and do the breathing as you can in between the chest compressions. And so some of the evidence, this is more evidence than the Research Outcomes Consortium investigators looking at 506 patients who had VTVF arrest and were not defibrillated before the EMS got there. And one of the neat things about some of our monitors are we can actually tell when CPR is going on from those same spikes. And we can look at, as a fraction of the entire code, how long were they getting chest compressions. This is looking at the percentage surviving. If only 0 to 20% of the time they're getting chest compressions, their survival is around 12%. Whereas once you got that chest compression above 60% of the time, you've more than doubled the survival to 26%. So these data suggest that the more chest compressions during resuscitation, the more likely you are to survive. And this is an example, and just an example of how to do this. We call it now cardiocerebral resuscitation, a term coined by Gordon Avey and others in Arizona. So you're doing 200 chest compressions, you stop to analyze, you shock them, and you start right back doing more chest compressions and get this patient back. Hopefully someday soon we won't have to stop to analyze it. The machines will take out the chest compressions and just know when to shock. So more evidence for this. One of the most amazing cardiac arrest interventions ever done was done in Arizona by Ben Bubrow and colleagues from the fire departments across the state and the health department. And they decided to train the entire state in chest compression only CPR and try to make a difference. Their findings were published in the Journal of the American Medical Association in 2010. So looking at their data over these 5 years, from 2005 to 2010, they had 5,000 adults who had presumed cardiac arrest that were not observed by EMS. And of these, 2,900 did not get any resuscitation, 1,500 did get resuscitation, and most of those got bystander CPR. And over time, I'll show you the chest compression only increased and the chest and breathing did not, it declined. So looking at the overall incidence of bystander CPR over this 5-year intervention, they went from a 28% rate up to 40% rate. And this is what we hope to do in North Carolina, increase to 40% and make a big difference. Looking at the application of hands-only or chest compression-only CPR, this went way up from 20% when they first started up to 75% of patients getting this chest compression-only CPR by the end of the intervention. So they clearly had an effect on the public. They both increased more effective CPR as well as the rate of bystander CPR. We can do that here. Most importantly, did this make any difference on these Arizonians having cardiac arrest? We're looking at all out-of-hospital cardiac arrests, comparing standard CPR to the chest compression-only CPR. The survival rate was significantly higher for those getting chest compression-only, 7.8% versus 13.3%. Looking at that special group of witnessed and shockable, the Utstein patients, about 18% for standard CPR versus 34% for bystander chest compression-only CPR. So we see a huge difference here, and numbers approaching Seattle, great survival. So overall, I think it's very important that we apply this chest compression-only CPR with massive public training and very effective resuscitation to get our patients back. Now I'm going to talk about the evidence for medical dispatch. Medical dispatch is very important. When you call 911, having someone on the phone who can help you with a cardiac arrest, they recognize the symptoms, they can instruct you, they can apply rapid first responders. That is so critical to surviving cardiac arrest. And there's some good evidence around this. The first piece of evidence comes from Amsterdam in Europe. They reviewed 506 cardiac arrest calls, listened to every tape to see what was going on. And their question was, if the dispatcher recognized a cardiac arrest, did that make a difference? So they reviewed these tapes, they found out that if the dispatcher recognized it, they were faster dispatched by about a minute or so. And they also were on scene faster, 8.5 minutes they recognized cardiac arrest versus 9.9 minutes without recognizing cardiac arrest. So only a minute and a half difference. But this difference made a huge difference in survival. if you look at this graph to the right, you'll see two survival curves. The top one for patients for whom dispatch recognized cardiac arrest, the bottom one for patients whom they didn't recognize cardiac arrest. What they found by 90 days, about 50% of patients for whom they recognized arrest were still alive, versus if they didn't recognize it, only 5%. So that minute-and-a-half time difference made a huge difference on surviving cardiac arrest. And the dispatch recognition was very important in knowing whether they get there quickly or not. And so what was the big thing as they listened to these tapes? Why didn't they recognize it? They thought the most common cause was not recognizing agonal breathing. So they asked if they're breathing, but they really didn't figure out that it wasn't real breathing, it was just gasping that is typically seen with cardiac arrest. So we'll talk more about this in this presentation, about how to recognize agonal breathing as cardiac arrest. Now this is a study from Tom Ray and colleagues up in King County EMS who are leading the Seattle effort. And this is looking at, over time, 3,000 patients who had either dispatcher instructed CPR versus bystander CPR versus no CPR. So the comparison group is patients who just didn't get CPR, just lay there and died. And the blue lines are patients who were treated by bystanders who were instructed by the EMS on how to do bystander CPR. And finally, the black lines here are cardiac arrest victims who got bystander CPR, and the instruction was not necessary. The bystanders knew how to do it. And these lines are stratified according to response time. So overall, compared to patients who didn't get bystander CPR, those patients who were treated by bystanders who had emergency dispatch instruction were 1.5 more times likely to live. And those patients treated by someone who knew CPR already were 1.8 more times likely to live. Now, dividing it by response time, less than 3 minutes versus greater than 5 minutes. For response time less than 3 minutes, that bystander instruction by the dispatch didn't make much difference. It's probably because they're there so quickly, there's no time to teach them over the phone. But the group where it makes the biggest difference are these response times greater than 5 minutes, which I think for North Carolina is most of our state, just given our geography. For those patients, it was hugely important that the bystander CPR that was initiated by the EMS dispatchers had a similar odds of survival as patients who had an arrest in front of someone who already knew how to do CPR. So this EMS instruction is very important in saving lives, and this I think is going to be a very important tool for North Carolina. And then what type of instruction? We keep talking about, we believe chest compression only CPR is better. Are other data for that? These are data published in The Lancet in 2010. This is a meta-analysis, so they combine multiple randomized trials of either instruction in breathing and chest compressions versus instruction in chest compressions alone, including another study from Tom Ray out of Seattle. And what you see is if the EMS dispatch is instructing on chest compressions alone, there's a higher likelihood of surviving, 1.2 times that of chest compression and breathing. This is really the first randomized trial evidence that chest compression only works better than chest compression and breathing, and also shows that this dispatcher instruction is so important.
Emergency police paramedical. Is he conscious?
No, he's not conscious.
Is he breathing normally?
Well, leave his head back to his airway.
Is he breathing normally?
No, not really.
Okay, then you need to get him out of the vehicle and lay him flat on his back because it sounds like we need to start CPR. Just get him flat on his back and kneel beside him.
Okay, and you want chest compression only?
Yes, hands in the center of his chest, right between the nipples. Put the other hand on top of that. Press down firmly with the heels of your hands about an inch. And what I want you to do is do it 50 times, 50, and count out loud.
Got it.
Do like 1, 2, 3, 4.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18.
Okay, well, if his chest isn't going up and down and it's really slow, just go ahead and keep with the CPR, okay?
Okay.
Is that the patient?
Yeah, he sounds like he's gargling on something.
Yeah, that sounds like he's got agonal breathing. Keep doing the chest compressions only, okay?
No, is that 911 on the phone? I'm on it. Make sure.
So what are the essential elements if you're going to put a program in place? And we have many programs in the state. We hope to have every time someone calls on the phone, there's a medical dispatcher who can tell you how to do CPR. versus training, which is part of the purpose of this video, as well as many resources across the state. Next is quality improvement. If we can implement the CARES registry across the state, we can actually track these rates of recognition and treatment and make them better. And then feedback to both the dispatchers and to the public. Having performance standards, and I think our standard for cardiac arrest will be to recognize every single call that's a cardiac arrest and do dispatcher instruction for every patient who needs it. And we can look at how long it took to recognize cardiac arrest. We can look at time to starting chest compressions, and we can look at the percent of cardiac arrests that receive telephone CPR. So now let's look at the evidence around hypothermia. So hypothermia is a medical term for keeping someone cold. And this is something we use all the time. Let's say in sports injuries, we ice them down, decrease inflammation makes us feel better. Well, what organ is more important to decrease inflammation than an injured brain from a cardiac arrest? So there's actually 2 randomized trials published in the New England Journal back-to-back which showed better functional survival with hypothermia. And we believe this is a very important intervention for a cardiac arrest patient. The first study came out of Vienna, and in this study they had 3,000 patients in Vienna who were assessed for enrollment in this trial, of which 275 were considered eligible for enrollment. And these eligibility criteria including a VT-VF arrest, so shockable arrest, the Epstein type of arrest, initiating resuscitation within 5 to 15 minutes, so pretty much a witness type of arrest where they quickly treat that patient. Less than 60 minutes to restoration of circulation, and really for the majority of these patients, really less than 20 minutes to get circulation back. And then in Vienna, they cooled them for 24 hours to a temperature between 32 and 34 degrees Celsius. But they did this very slowly. It took them 8 hours to achieve target temperature. They used cooling blankets and ice packs, so fairly simple interventions here. This slide here shows the results of their studies. So there's 2 rows. The first would be surviving, and the second row is having a favorable neurologic outcome, which we think is even more important. Not good enough just to survive, it's to be able to survive and return to your life and your family. So looking at the 2 columns on the right, middle column is hypothermia group, and the right-hand column is a normothermia group, or the patients who were not cooled. What we see is huge differences. In terms of survival, 64% of patients who were cooled survived versus 50% for the normothermia group. In terms of favorable neurologic outcomes, so could they walk, take care of themselves, think, 47% for the hypothermia group versus 31% for the normothermia group. So in terms of medical results, these are hugely different findings in a randomized trial, and this is very, very strong evidence that cooling makes a big difference, even when it's applied very slowly. The second study, published in the same issue of New England Journal back in 2002, came out of Australia. Very similar in Melbourne. They had 77 patients who had VF arrest. All of them had return of spontaneous circulation, and they remained in persistent coma. So to your typical cardiologist who doesn't do the huge neurologic exam, I define coma as they cannot follow commands after the arrest. That's who we would cool. In Australia, they randomized them on even or odd days to either getting hypothermia or normothermia. They didn't cool them as long. They cooled them for 12 hours to 33 degrees rather than 24 as was done in Vienna. But they did it much faster. They began at pre-hospital, and they only took 2.5 hours to get to this target temperature of 33 degrees. Again, just using chemical and ice packs. What were the results? Just as, I think, remarkable as those from Vienna. Looking at these on the right-hand side, for the hypothermia group, 49% had a favorable neurologic outcome versus 26% for the normothermia group. It's almost a doubling of this the better outcome. Again, statistically significant and I think very important and convincing that hypothermia really makes a big difference. So we know this works, and we know it saves lives, and we know that it returns people to a functional life. But there's lots of questions that remain. Who do you cool? And again, I think it's someone who has return of spontaneous circulation, who's not following commands. We're not sure, is it just VT-VF like these 2 trials, or is it everyone? How do you cool them? There's many ways, from the chilled saline in the Coleman cooler to using an intravascular device. When do you start? We believe earlier is better, but we just have their best evidence for the in-hospital cooling. How long do you cool them? Based on these trials, we believe around 24 hours, but it could be longer, could be shorter. What temperature? It seems that 32 to 34 degrees is a good spot where they don't have too much hemodynamic compromise, but it has enough cooling just to save the brain. How fast do you rewarm them? We believe in the order of 12 hours or so, but again, this is subject to study. And lastly, I think most importantly, when do you look for neurologic recovery? When I started in medicine, when someone had out-of-hospital cardiac arrest, when they came in, they pretty much didn't respond, and this was all due to the trauma of the arrest. By the next day, though, they'd often wake up and follow commands, and if after 3 days they weren't, they were not probably going to make it. That's all changed with hypothermia and cooling now. We see patients 5, 6 days out who are now waking up, and we need to change our protocols for assessing recovery. And my neurology colleagues are very good at doing that. So the last piece of evidence for hypothermia comes from Abbott Northwestern and the Minneapolis Heart Institute. So Abbott is one of the leading facilities in the country for emergency cardiac care, and I have to say many of the things we do in North Carolina have been modeled after Abbott Northwestern. I also joke that in Minnesota, because of the temperatures, hypothermia is not a big deal. You just open the windows and you're looking good, whereas North Carolina things are much more challenging, particularly in, let's say, mid-August or so. These are data just presented by Dr. Money and colleagues looking at their outcomes for cardiac arrest for cooled patients. They had 140 patients at Abbott Northwestern, of which 106 were transferred to the facility. All these patients had returned to spontaneous circulation and were unresponsive, and again, that would be not following commands. And an amazing recovery rate. 56% were discharged alive, 51%, or half of them, had good neurologic outcomes. Really excellent results. And these are very encouraging, and again, we want to see these in North Carolina. They're probably also select patients. Who gets on a helicopter to go to Abbott Northwestern is probably somebody who's more likely to make it. So what Dr. Money and colleagues did is they looked at this time to cooling from the return of spontaneous circulation to when they were cooled. They divided this into 3 groups. They were cooled between 0 and 39 minutes, cooled 40 to 102 minutes, and then more than 102 minutes. What they saw is the earlier this was started, the more likely they were to have a good neurologic outcome. From 45% waiting over 102 minutes up to 60% doing it within the first 40 minutes or so. So this is evidence, at least, that earlier cooling makes a difference. And so you'll see across North Carolina, from Wake County actually starting cooling during chest compressions to many areas initiating cooling in the field and doing it for all cardiac arrest victims. You'll see more and more earlier initiation of cooling.